Welcome to this Step 3 review on Goals of Care discussions. This video is brought to you by Roadmap to Residency. Goals of Care questions show up again and again on this exam, and they reward the doctor who protects patient autonomy and knows exactly who decides and what document controls. Our goal today is not to reteach the whole topic. It is to show you how the question stems are built and how to attack them quickly. Make sure you are also working through your question bank and a trusted review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn how to read the clinical vignette to figure out who is allowed to make the decision and what this particular patient would have wanted. Second, we will separate the four ideas that these questions constantly blur together, which are advanced directives, portable medical orders, code status, and surrogate decision-makers. Third, we will drill the trigger phrases that point you straight to the right next step. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to always find the decision maker before you find the treatment. Start by asking who is allowed to speak for this patient right now. If the patient has decision-making capacity, the patient decides, and nothing the family says can override that. If the patient has lost capacity, look for a named healthcare agent or healthcare proxy first, because a person the patient chose outranks the default surrogate list. Once you know whose voice controls, most of the wrong answers fall away. Then center the patient's own wishes. When a surrogate has to decide, they are supposed to use substituted judgment, which means choosing what the patient would have chosen, not what the surrogate personally prefers. Train yourself to notice any answer that quietly swaps in the family's comfort or the team's convenience for the patient's actual values. Strategy 2 is to respect capacity and autonomy, and this is where a lot of test takers get pulled into the wrong answer by a worried family. First, remember that capacity is decision-specific and can fluctuate. A patient has capacity for a given choice if they can understand the information, appreciate how it applies to their own situation, reason through the options, and clearly communicate a preference. Crucially, a label like dementia or depression does not by itself strip capacity, and choosing something the team would not choose is not evidence of losing it. Second, autonomy outranks family wishes. A capable adult can refuse any treatment, including one that would save their life, and relatives cannot veto that decision. When the STEM goes out of its way to tell you the patient understands the consequences and still says no, the right answer almost always honors that refusal, rather than seeking a court order or pushing treatment anyway. Strategy 3 is to sort the documents and the people, because these questions live or die on precise definitions. First, tell an advanced directive apart from a portable medical order. An advanced directive, like a living will, records what a patient would want in the future and can name an agent, but by itself it is not an order the team acts on instantly. A portable order, such as a physician order for life-sustaining treatment, is a signed medical order that takes effect immediately and travels with the patient between settings. When the patient is acutely ill in front of you, the signed portable order is what guides care. Second, know the default surrogate priority order for when no agent was named, which typically runs guardian, then spouse or partner, then adult children, then parents, then siblings. And remember that a healthcare agent, the patient personally chose, sits above that entire list. Third, do not confuse do not resuscitate with do not intubate. Do not resuscitate means no compressions or shocks. Do not intubate means no breathing tube. They are separate choices, and neither one means you stop treating the patient or stop keeping them comfortable. Let us work through our first practice question, and this one tests whether you can find the decision maker. A 70-year-old man is in the hospital with severe pneumonia and is now confused and unable to make his own decisions. 2 years ago, he completed paperwork naming his daughter as his healthcare agent. At the bedside, his wife, his daughter, and his adult son are arguing about whether to escalate to the intensive care unit, and his breathing is getting worse. The question asks who the team should turn to for decisions. Notice that a specific person was formally named while the patient still had capacity. Read the 4 options carefully and pick your answer, then we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the key fact. The patient has lost capacity, so the team needs a substitute decision maker, and the vignette tells you that while he still had capacity, he formally named his daughter as his healthcare agent. That named agent is the whole point of the question. Next, apply the rule. A healthcare agent the patient personally chose sits above the default surrogate list, so the daughter outranks even the spouse, and she now makes decisions using substituted judgment, choosing what her father would have wanted. Finally, eliminate the wrong answers. The wife is a trap that relies on you defaulting to the spouse, but a named agent beats the default order. Letting the team simply pick whichever relative seems most reasonable throws out the legal hierarchy, and going to a judge for an emergency court order is unnecessary when a valid agent already exists. The correct answer is the daughter, the named healthcare agent. Notice how finding the decision-maker instantly settled the whole case. Here is our second practice question, and this one is all about knowing which document actually controls care in the moment. An 80-year-old woman with advanced heart failure arrives at the emergency department in cardiac arrest. Her son hands the team a signed portable medical order for life-sustaining treatment that clearly documents do not resuscitate. He also mentions she once wrote a living will, but he cannot find it. The team has to act right now. The key here is to recognize the difference between a signed, active, portable order and a living will that expresses wishes, but is not in front of you. Pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, identify the active order. The team is holding a signed portable medical order for life-sustaining treatment that clearly documents do not resuscitate. That is an actual medical order. It is valid across care settings, and it takes effect the moment the patient arrives. The living will the son mentions is not in front of the team, and does not override a signed order that is already in hand. Now, why does the portable order win? Because it directly expresses this patient's documented wish, and honoring it means the team does not resuscitate. Beginning full resuscitation while someone hunts for the living will delays care and treats a valid signed order as if it were in doubt. Asking the son to decide whether to start compressions ignores the patient's own recorded choice, and there is nothing in the stem suggesting the order is expired or invalid. The correct answer is to honor the signed portable order and not resuscitate. Let us talk about how these questions frame code status conversations, because the communication answer is often the one being tested. First, explore values before checklists. When a STEM asks what you should do or say next in a goals of care discussion, the best answer is usually to ask the patient what they already understand and what matters most to them, rather than immediately asking a blunt yes or no about chest compressions. An open-ended, empathic question that draws out the patient's values almost always beats jumping straight to the procedures. Second, do not abandon or overrule the patient. A do not resuscitate order does not mean you provide less care, so the right answer keeps managing symptoms, offering appropriate treatments, and supporting the patient and their family. Be very suspicious of any choice that reacts to a code status decision by pulling back beneficial care or by pressuring a patient to reverse a clearly expressed wish. On this exam, respecting the patient while continuing to care for them is the winning move. Here is our third practice question, and it rewards respecting autonomy. A 65-year-old man with widely spread cancer is admitted with pneumonia. He is alert, fully oriented, and he clearly states that if his heart or lungs fail, he does not want to be intubated or resuscitated, and he understands this decision may shorten his life. His adult children are pleading with the team to do everything and keep him full code. The question asks for the most appropriate next step. The detail that should jump out is that the patient plainly has capacity and understands the consequences of his choice. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, recognize the capable patient. He is alert, oriented, and able to explain both his choice and the fact that it may shorten his life, which is exactly what having capacity looks like. A capable adult is allowed to refuse intubation and resuscitation, and his own instructions control his care, so the correct step is to honor his wishes by entering "do not resuscitate" and "do not intubate" orders. Now, the key distinction among the wrong answers. Following the children and keeping him full code overrides a capable patient and violates his autonomy, which this exam will not reward. Requesting a psychiatry hold to question his capacity is inappropriate because simply refusing treatment is never proof that capacity is gone. Seeking a court order to override him is unwarranted when a capable adult has made an informed choice. Every distractor does the same forbidden thing, which is overruling the patient. The correct answer is to honor his wishes and enter, do not resuscitate and do not intubate. Here is a pearl that ties all of these questions together, and it is the autonomy ladder. Always work from the patient outward. Your first question on any goals of care item is, what did the patient say or want? If the patient has capacity right now, their current wishes control everything. If the patient cannot decide right now, look for their own prior instructions, whether in an advanced directive or a signed portable order, because a clear expression from the patient, present or past, almost always outranks what family or the team prefers. Only when the patient's own wishes are genuinely unknown do you climb to a decision maker, and even then you start with a healthcare agent, the patient named, and only after that fall back to the default surrogate order. Remember that whoever the surrogate is, they are still bound to choose what the patient would have wanted, not what they want. Climb this ladder in order: patient first, then their documents, then their chosen agent, then the default surrogate, and the large majority of these questions solve themselves. That wraps up our review of goals of care discussions for Step 3. Remember the core ideas we covered today. Find the decision maker before the treatment, and always start from the patient's own wishes. Respect capacity and honor a capable adult's refusal, even when the family disagrees. Keep advanced directives, signed portable orders, code status, and surrogate hierarchy clearly separated in your mind, and climb the autonomy ladder in order every time. The best way to lock all of this in is to drill questions in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.